Dr. Lebovics, I'm going to start out with a couple. There have been a lot of questions about ears, nose, throat, in addition to the airway. So we're going to get to some of those. But one of the first ones is there a way to determine that damage is occurring to the nose from vasculitis early enough to stop further damage from happening?
Well, these are great questions. And, when you talk about ear, nose, throat, a lot of it has one thing in common. All of that has that respiratory epithelium, the first thing I mentioned. So that's why the GPA targets those areas. As a general rule, again, I like the fire analogy. Your question is, if the nose is on fire, the sooner you call in the fire brigade, the better off you'll be. So obviously early diagnosis is critical, or certainly very helpful. The sad reality is often people don't get a diagnosis until, sometimes it's years, and the hell that some people go through is terrible. And I don't judge anyone because, we talk about zebras. Most people don't think in those terms. The one thing I learned in internal medicine is that the most common diseases happen most commonly. So you always have to play your more common hand. So the question, I think, is, can this affect the nose? How do you find it early? Was that it? Just want to be sure I understood the question. Yeah,
it was. Is there a way to determine that damage is occurring to the nose from vasculitis early enough to stop it from being so bad when many people are finding out? Could they have done probably?
Well, okay, so the question is, what does so bad mean? Does it mean a collapsed nose, a saddle nose deformity? Does it mean losing your septum? Is it crusting? Is it infection? Is losing your ability to smell? Is it bleeding? Is it disease that now goes to a contiguous structure, a structure that's next door, like the orbit, the eyeball, sometimes the brain from the sinuses? So the answer is, of course, sooner the better. And in theory, somebody will come to the doctor and say, my nose is blocked, it's congested. And if you do have systemic vasculitis, often it's not the most common or first thing on most doctors' mind, and rightfully so, because you take 100 people who present like that, 99% of them will not have vasculitis. So it's hard to say, what do you mean by how much like that? It could always be worse. And, I didn't bring clinical slides because I could show you sometimes some real horrors. And so I often tell people, as bad as it is, you'd be surprised how much worse it could be. One thing I noticed about, Mr. James and Ms. Haggard is they both have tracheotomies, talking about how worse it could be. And they seem to be doing very well with it. It seems one's happy leaving it, the other doesn't want to push it. And that's a completely reasonable and solved approach. And, I support their decision to make those, how those things affect their bodies. So if you want to go more into ears, we could talk about ear issues, sinus issues, nose issues. I'm not sure, because these are good segues.
I think everybody wants to talk about all of them, but I'm going to stick on the nose for a minute, and then I am going to the ears because there are multiple questions about the ears. But one of the things that came up very commonly is, could you please talk about saddle nose that occurs with some patients who have sinus infection? Does the damage occur quickly or over a long period of time? Are there surgical options to address the issue before too much damage happens? And what surgical options are there once the nasal area is collapsed?
So that you're talking about, that's a lot. So the saddle nose deformity, I'm going to use a little jargon for 1 second, is the loss of the dorsal septal cartilage. The nose itself has different cartilages. There's a lower lateral cartilage, an upper lateral septal cartilages. It's not the important what, but when you have inflammation, think of this word as inflammation in my world is a euphemism for the fire. There's a fire in your nose, which eventually causes blood flow to stop to these cartilages. Remember, cartilage doesn't have much blood in it. It's not like the liver, or the kidneys, which get a lot of blood. So it doesn't take much for cartilage to die. Clearly, if there's an active process, we talked in the first slides about differentiating active disease from damage, which comes after the active disease, or when the fire is raging to what's left afterwards, you have to put out the fire if it's raging. Now, that's generally medical, and that's why I work closely with the rheumatologist or the lung doctors. Nobody can do this alone, I promise you. It really is a team approach, and you have to be humble in this business. Once you ask, can it happen quickly? Yeah, I've seen people go from a normal nose to a significant saddle in between 6 to 8 weeks, and that's relatively rapid. As the cartilage starts dying, the nose starts collapsing. It's an anatomic defect. Now, when someone's in the active phase, I will not reconstruct them, but if the fire is out, so to say, and you have them now where things are in remission and we expect things to stabilize, the answer is yes, there are different repair techniques. And I've done actually a bunch of saddle nose repairs. The way you do it is you have to now replace what's lost, which means either cartilage or sometimes bone or sometimes elements of both. I can tell you I've taken the bone from the skull, from the elbow. Usually now, most of the time, we take cartilage or cartilage and bone from the ribs. You can get what's called bank bone from a lab, a cadaveric graft that has pros and cons. The biggest pro is that you don't have a donor site, so it's one operation instead of two at that time. To me, the con is you're getting a cadaveric transplant, and this age of who knows what. Even though these things are sterilized to everything known to man and they're approved by the FDA, some people don't like that idea, and I respect that also. But there are ways of reconstructing the nose. I always say I go for the bronze medal, not the gold medal. We've had a couple of golds come out more by accident. I've seen what happens when people, I actually once published a paper on what can go wrong in a saddle deformity, why I think some people make mistakes when you use standard nose job techniques. And that's the stuff I tend to avoid. I usually do it with a colleague, a friend who's a plastic surgeon, and we kind of yin and yang it. He's trying to make it perfect, and I'd say stop, and it's don't. Oh yes, no, it's almost like a little hardy in the operating room, kind of fun. But we've had, thank God, never had any meaningful complications. We've only had good results. So there is hope, there is redemption. I just want to stress that in terms of the nose, and that's from a functional perspective as well as a cosmetic perspective. I'll just throw one other note. I've said a lot of people say, oh, it's just a collapsed nose. I know a lot of people find it to be one of the most devastating complications because people see it. We're our face. Our face is our face to the world. The nose is the mid-third going horizontally and vertically. I've heard women, cry to me. She's tired of the jokes saying, what's the matter? Your husband's still beating you up or something. To some men, saying they're tired of people saying, oh, I'm still putting the cocaine in your nose. It's very, very hurtful to these people. And by giving them some hope and redemption, you do good. I'll just give you one anecdote. This is probably almost 20 years ago. It was just a lovely girl who had GPA Wegener's and an associated disease called Crohn's disease. There's an association between the two. It's a GI disease. She was a young girl in her early 30s, was a school teacher in nursery, and she wanted to meet a guy, wanted to get married. And it was a devastating thing for her. And one day when she overheard the kids, these are 4-year-old kids, playing a game and talking about, something about the monster. And then she realized she was the monster. She just lost it. And she's the only girl I ever actually operated on who never got off all her immunosuppressives. And it went well, for years. I was getting a card for once a year for about 7-8 years, and so there was a happy ending to that story.
Well, good for a happy ending.
Yeah.
Thank you for addressing part of the nose questions that we've had. There are many more. I am going to, just because we could go on forever. We're running short on time. I just want to jump to the ears for a minute. And because there's a lot of questions. The first one I saw was, can you speak a little bit about how GPA affects hearing? I've lost a bit of hearing on my left side, but I'm unclear as to the mechanism aside from what you mentioned in the beginning. And there are people who have asked about, I always say it wrong, tinnitus or ringing of the ears. So if you could address some of that, that would be great.
Sure. So the ear really comes in two halves. We call it the middle ear an outer ear, which is the mechanical portion, and the inner ear, which is the nerve portion. Hearing loss can come from mechanical obstruction or from nerve disease, or sometimes both. The most common hearing loss is the hearing loss of aging. It's called presbyacusis. And that's as we get older, the hearing nerves sort of wear down a little bit, like a lot of things in our body. Let's go back to the very first slide. When I think of, again, this is a disease of respiratory tissue. And I said the middle ear and the mastoid is respiratory tissue. So just like you could have a fire in your nose, you can have a fire in your ear, or even a small one. It's a very small cavity that makes fluid, and that little fluid's got to go out of the ear through something called the eustachian tube into the back of your nose. The nose could be blocked in GPA. The middle ear could be blocked. So if it doesn't drain, what's going to happen? Well, I can tell you, it's not a question of if, but a question of when is A going to get infected. And B, when the middle ear does not drain, you get a backup of fluid. And the most common operation in the United States today, I think, is still putting tubes in the ears of children when they have fluid in the ear. In order to drain that fluid, you short circuit the system by putting a hole in the eardrum, a little grommet, you suck out the fluid. Any fluid that comes on, that comes out the ear canal instead of the middle ear, down to the eustachian tube. And the great thing about this, I mean, it's instantaneous. I mean, the hearing is better by 99%. They have a 10,000-fold improvement in their hearing almost instantaneously. If it's mechanical, you often have to keep that tube in for a while. Children, they have to be put to sleep for that, but adults will do in the office. It's a 10-minute procedure. It's actually very gratifying when someone says, I can't hear, and then they're clogged and then they can hear. So that's one part of it. Now, GPA Wegener's can cause what's called a nerve-based hearing loss, because the back of the ear, when you go towards what's called the promontory, where you have something called the oval window, the round window, that's the area where you get into the nerve side of the hearing. And that part of the ear is a little different. It can be subject to toxins that go through this window. It can cause inflammation of the nerve. And if you have a nerve-based hearing loss in GPA, I consider that actually very serious. I work very closely with a doctor in Manhattan. His name is Robert Spire, who's just terrific. And I think he gets it, because a lot of rheumatologists, someone has foot drop, if a peripheral nerve will be affected by the vasculitis, by the GPA, steroids or toxins, it's like a whole big to-do. But the hearing nerve is a cranial nerve, and that's really going to the brain. And a lot of people, it's hearing loss. So a lot of people don't realize, the morbidity, what it does to patients, how miserable you are when you can't hear. It defines our humanity on the one hand. The other side of it also may be representing some form of disease that's going into the brain, into the central nervous system. Concurrently, the hearing nerve is right next to the vestibular nerve, or the balance nerve. So a lot of people, if they have inflammation of the hearing nerve, can end up with what I call true vertigo. More dizziness, not dizziness. Dizziness is weakness. Vertigo is motion. And that's a very debilitating symptom also. Whenever the inner ear is diseased for any reason, including from GPA, you can get basically nerve endings that are firing off incorrectly, and you perceive that as noise or tinnitus. So that's part of the reason why it happens in the inner ear, secondary to what's going on in the middle ear. If you drain the ear early, that's usually a very good prognosis to help the hearing come back. I've been seeing I never published this, but I've seen lots of people with nerve disease in the ears get better when you put tubes in. So I'm a big proponent of tubes in GPA patients. Be aware it can affect the balance system. And just like the sinuses are contiguous or next to the central nervous system, which is a euphemism for the brain, same thing with the ear and the mastoid. So you always have to look, not only where the organ is, but what can happen next door. Hearing is important for ability to communicate, hear, our sense of balance, and really to function in this world. So I take it very, very seriously.
Okay, thank you so much. There were questions about something called eardrum retraction pockets and eustachian tube dysfunction. Does that fit in with what you were just talking about?
Exactly. So if you go into when the middle ear is a little cat, so it's almost like a little tiny cube. that makes fluid. Remember, our nose, the paranasal sinuses make fluid, and it drains. Our lungs made a quart of mucus every day. It drains, and it's there physiologically. Well, the same thing, this respiratory epithelium in the middle ear also makes fluid, then has to drain. The problem is, what happens if it doesn't drain? Well, ask anybody with a stone in the gallbladder when the gallbladder doesn't drain. It's not good. Ask somebody who has a bladder that doesn't drain for whatever reason, they're not very happy to get to the emergency room very, very quickly. Well, the same thing, if the middle ear doesn't drain, the hearing loss will occur relatively quickly because the eustachian tube is either not working well, the ear is inflamed, or you know what? In GPA, the nose itself can be blocked. The eustachian tube ends in the back of the nose, and if it's swollen, blocked, or has crust there, the middle ear may be fine, but the nose may not be accepting the drainage. So you'd have to look and see where the blockage is in that system. Again, like a respiratory tract. The hearing loss may be caused by a nose problem, as strange as that may sound. A retracted pocket means there's a pressure imbalance where the eardrum gets so sucked in that it's no longer really, but it's almost lining this thing called the back of the ear. And to put a tube in there is almost impossible. I always send those to the ear doctors, because that's tough to do, and usually needs a surgical solution of lifting up the eardrum and putting a tube in from behind. But you can have a retraction pocket, you can have eustachian tube dysfunction, either primary or secondary to the vasculitis.
Okay, Dr. Lebovics, we are at 1 hour right now, which I can't believe because I feel like we have another 45 minutes of questions, which, good news, we will take care of that in the second half of this towards the end of July. I had one question that I feel like may be a sort of simple answer that might help a lot of people, maybe not. The last question was, for those who have had upper airway and ear involvement, do you recommend any kind of surveillance or things to watch for in terms of monitoring for lower airway involvement, like regular chest x-rays, blood work? This person has been diagnosed since 1998, so they're just wondering how to protect their future.
Right, that's a great question, and I'll just jump and say, this is what I tell my kids all the time, is the best way to deal with problems is to prevent them. That's number one. Once you have a diagnosis, which is already often more than 50% of the problem, have your antennas up, surveillance is critical. And sometimes you can have an abnormal blood test, a small something in the nose, the joint pain can come. A good rheumatologist will say, come early, because you can quote me, as a doctor, you almost never get credit for something that didn't happen. It's a very powerful thought. So you want to prevent recurrence. You all know Anthony Fauci from COVID fame. His most famously quoted paper ever is actually a review on 158 patients of GPA. I was actually honored to be on that paper as well. And it's considered one of the gold standards. But the reason I mentioned that paper is the upshot of it is that left untreated in this cohort, and these were the more classical GPA patients, 80% of patients with GPA will flare within 5 years. So the concept of surveillance is very important. Nip it in the bud. That was before rituximab was around and available to treat this. I think I mentioned before, I think it's a game changer. I like the analogy, again, if you're smelling smoke, call the fire department early.
Right. Thank you so
that's
much.
This is a fire of the airway, and you got to put it out however you're going to do it, and then let the builders and the contractors figure out how to reconstruct things.
Yes, great advice. Thank you so much. And I will say, on behalf of all the patients that are in here, since I am also a patient with MPA vasculitis, thank you so much for sharing your time and knowledge with us. We always have questions, and we don't always have the right doctors or resources to ask those questions. Speaking of resources, many of you, there were comments in there about, I mentioned a vasculitis center. There are vasculitis centers all around the United States and in many other countries, but you can find that information on vasculitisfoundation.org. there's a tab on there called Find a Doctor. And you can find a vasculitis center or a doctor who's commonly treats vasculitis through that resource. And I believe very strongly in it if you haven't noticed. So thank you so much, Dr. Lebovics. Thank you, Cheryl.
Yeah, I just want to echo that. I mean, you can't say that enough. Knowledge is power. The more you know about this disease and the manifestations, you'll be better. The foundation, that's what they specialize in, giving you information. I used to be on the board of directors probably about a decade ago, and I was just thrilled. One of the things we were pushing then was to put these vasculitis centers up and provide the seeds. I said, let's plant the seeds now. We'll see what happens in 10 years. Well, they're growing. And people, instead, if you live in Idaho, you at least can go to Utah. You don't have to travel to Washington or to New York. And we need more of them.
And I live in North Carolina, and I only travel 40 minutes to mine. So
Chapel Hill is the center.
Yes, I'm very fortunate to have the center and the doctor there. Thank you so much to Victor and Cheryl for sharing your story. I think it's really great for other people to hear how you live on and how well you live on. That's another part of something important that's coming up in future Vasculitis Foundation information. It's called Victory Over Vasculitis. We have really great people who can share how they're going on with their lives. And so, as always, thanks to the Vasculitis Foundation for hosting this important webinar series. And a great way to stay informed with the Vasculitis Foundation is to subscribe on their website to Vasculitis Foundation e-News. You'll get a publication about every month, and that'll keep you informed with all of these things and learning more about this. Some of you found out about on social media about this, but there are other ways to find out as well. So be informed. And the Vasculitis Foundation website is the best way to learn more about the organization as a whole, the websites, the different kinds of vasculitis, the Find a Doctor, all the links to all these webinars that are recorded and posted later. So thank you so much to everybody for being here, and we'll see you again in the end of July to answer the rest of the questions. Sorry we didn't get to them all.